afternoon, and welcome to Module 3 of Huntington's Disease and Physical Therapy. This particular module is being brought to you by Lori Quinn, who is with the who's an Associate Professor of Movement Science and Kinesiology, Department of Behavioral Studies, and is a consulting physical therapist at the Huntington's Disease Center of Excellence at Columbia University Medical Center. Dr. Quinn has worked with patients with Huntington's disease since 1992, and her current research is on developing clinical trials to assess the benefits of exercise, of physical activity, exercise, and rehabilitation in people with Huntington's disease. She has most recently lived in London and was a senior research fellow at Cardiff University in Cardiff in the United Kingdom from 2007 to 2014. We'd like to thank the American Physical Therapy Association for their partnership in developing this course. Before we begin, I want to just bring 2 points to your attention. The first is that the handout for today's session is available, and you should download it during this discussion so that it is available to you after the broadcast. If you want to ask a question, there is a small control panel that appears on the right side of your screen. You can ask a question at any time, but they will be addressed at the end of the presentation. So just type in any question or questions you may have, and then click on the send button, and Dr. Quinn will answer them at the end. And now we're going to go ahead and turn it over to Dr. Quinn.
Okay, let's get the slides up. Okay, so hopefully that everyone can see my slides. So thank you very much. I'm very pleased to be here and to be speaking to all of you on the topic of physical therapy management of individuals with early to mid-stage Huntington's disease. Just as my disclosure, I have no personal financial relationships to disclose at this time. The objectives of this course are fourfold. So first, to describe the role of physical therapy in Huntington's disease. I'm going to very much have an evidence-based focus to this intervention, this talk. If I had given this presentation even just a few years ago, I really could not give this kind of an evidence-based talk because there wasn't the evidence available. So since 2012, we've had almost an explosion of research in this area, and it's really at a very exciting time. And I certainly think this talk will need to be updated relatively quickly because of all the work that's being done. So I'll present the research that's been done to date on rehabilitation and physical therapy interventions. And again, we are going to be focusing on the early to mid stages of the disease. The third objective is to discuss the role of exercise and physical activity in thinking about self-management of the disease. And then finally, to discuss the contributions to fall risk and to outline falls risk management guidelines for Huntington's disease. I'll start off first by doing a little bit of a historical background of the development of physical therapy interventions before we get into some of the specifics. So we might ask what the role of physical therapy might be in a degenerative disease such as Huntington's. Now, some of you may have listened to the previous webinars that have been done, so I'm not going to go into the details about HD progression, but it does progress over about a 15 to 20 year period. And what you can see here is sort of before symptom onset. There's sort of this time period where people are known to be HD gene carriers but do not show clinical symptoms. They don't show signs of the disease, and these are typically called pre-manifest, or as they start to approach the onset of the disease, you also hear the term prodromal. And then once motor symptoms, this is typically the way that diagnosis is made, once motor symptoms are shown, people are considered to have positive clinical signs of the disease and symptom onset which progresses over a period of time. So over this time period, we have this progressive loss of neuronal dysfunction, which happens even prior to the onset of any outward symptoms of the disease. So what role might physical therapy play here is, ideally, I think we'd like to be thinking about intervening at a very early stage where we might actually prevent the onset or delay the onset of the disease over time, so that possibly exercise and lifestyle and environmental factors may have an important role in delaying the onset or preventing the onset. But I think where physical therapy is right now, not just in Huntington's, but in most degenerative diseases, is potentially in delaying death and improving quality of life and functional abilities in this period here, where there are symptoms of the disease, but we're trying to sort of slow the progression and delay death. So, and I'm going to talk about the differences about delaying onset and delaying progression and sort of the functional aspects of the disease. But the sort of our scientific basis, if you will, for physical therapy in HD, one can look to the environmental enrichment literature that's been done in the early part of the 2000s by DeBrossi and Dunnett and also Hockley, and there's been quite a lot of work done in the last 15 years in this, where animal models of Huntington's disease have been put in two different conditions. One on the right there, what we call an impoverished environment, where there's not much going on, there's no wheels or activities or things to do for the mouse, versus what we call an enriched environment. So the term environmental enrichment comes from here, where things in the environment are very plentiful. There's lots of things for the mice to do, to play with. There's wheel running, there's climbing, there's reaching, grasping, lots of sort of task-specific practice and activity. And what this research has shown us is that environmental enrichment has been shown to delay the loss of various brain function, motor functions, and specifically peristriatal cerebral volume has been shown to delay that loss, as well as a decline in motor function in these, and there's different types of mouse models in Huntington's disease. And you can see that here on this graph, where mice who were in a non-enriched environment had a lower grip strength at the end stage compared to those even who were in a minimally enriched environment, and also certainly compared to a highly enriched environment. So there was a functional correlate, which was grip strength, as well as a very specific change in peristriatal volume, which the striatum is the major area of cell loss that we see in Huntington's disease, again, even prior to onset of motor symptoms. This has also been shown specifically in wheel running, so not just the environmental stimulation, which one of the arguments with environmental enrichment is that it's not just the exercises or the activities that the mice are doing, because they're around other mice, so maybe it's the socialization as well that's a big part of the environmental enrichment effect, if you will. But it's also been shown in wheel running, where they had mice from a very, very young age, so definitely what we would consider pre-manifest, doing wheel running exercises, and they showed a delay in the onset of some of the motor deficits. And you can see here, these are the percentage of mice who actually failed these certain tests, a rotor-rod test and a clasping test. And that onset was delayed in those who were involved in wheel running compared to the non-enriched, quote-unquote, HD mice. And you can see that in both of the graphs here, very, very significant delay in the onset. And so there's some indication that this exercise or the environment might have an effect on delaying the onset or delaying the progression of the disease. So we take that research and we try to think about that as far as physical therapy goes, and where have we gotten to with some of the PT work in Huntington's? Well, around that time that all of that environmental enrichment work was done, there was basically no research on physical therapy and Huntington's disease. There was basically 2 case studies that had been published and some sort of anecdotal reports, but nothing to speak of, and certainly no randomized control trials. And as we've progressed over the last decade or so, we've seen a progressive increase in the number and, importantly, in the quality of studies that have been produced. And that's what I'm going to speak to you about today. this a little bit more in terms of our background and how we got to this point. I've done a lot of work with the European Huntington's Disease Network, which is a group of therapists throughout Europe, and actually we have some affiliates in the US and in Australia, who've tried to, again around 2008, 2009, develop some clinical guidelines and a framework for rehabilitation in Huntington's because we had no evidence to speak of. So one of the things that we developed was this framework for working with patients with degenerative diseases and specifically with Huntington's disease. So we looked at the stage of the condition and thinking about the classification in terms of the ICF, what main problems patients had, the management strategy and the goals for patients. So in pre-manifest, so this is again before any overt clinical motor symptoms primarily, the classification of function is we're mainly looking at the medical condition. We know that there's something going on, some degenerative process that's happening within the brain, but it's nothing that we can see. There's no functional deficits, there's no impairments. So our management strategy is really preventative in nature. We know the progression of the disease that is coming down the road, and by knowing that information, we may help to prevent maybe have a primary prevention in delaying the onset, as we talked about, but even secondary and tertiary prevention, where we're preventing some of the secondary complications from the effects of dystonia, from the balance problems that may be happening, and importantly, this would be delaying the onset of the mobility restriction that, again, we know is coming down the road in HD. So again, it's that altering that time course. Once patients start to develop clinical signs of the disease in the early to what we call early middle stages, you will start to see some impairments and activity limitations in the way of impaired balance, weakness of stabilizing muscles, which again might be primary or secondary issues, and dystonia and choreic movements. Now, interestingly, chorea, while it is a hallmark sign of many patients with HD, it's often not the most disabling motor problem that patients have, and we see problems more with dystonia and balance and force modulation as being more problematic than the chorea itself. So our management strategy at this point would be restorative. If patients are at falls risk, if patients are having specific problems, we're working to try to restore them to some prior level of function and maintaining that level of function to be as high as possible. And then as we progress to the late middle or the later stages of the disease, we have a range of impairment, activity limitations, and participation restrictions with a very high falls risk, mobility problems, postural changes. Pain may come in at this point. The dystonic posturing may result in decreased range of motion, and respiratory problems, which are the #1 cause of death in patients with HD. So our management strategy changes at that point to be more supportive in nature and possibly palliative at that point. And we're really trying to limit the impact of complications from the disease. So I think as an overall framework, this is kind of what we take with us to guide our physical therapy interventions, and I'm going to be focusing this talk today on the early to early middle stages of the disease, of what we know we can do at this point right there. So one of the things our group did was to develop clinical guidelines, and we determined that there were approximately 7 different classifications of patients going off of this progression from kind of pre-symptomatic early until the later stages of the disease. And we developed classifications for different patients. So early on, where their patients are pre-manifest, there's no motor impairments, but there are the potential for cognitive and behavioral issues, and they may really benefit from having exercise and physical activity, all the way down to balance, mobility, and falls risk. Some patients who have secondary and adaptive changes due to deconditioning, postural problems, respiratory dysfunction, and as I said earlier, palliative care. And what we did was, I know this is quite a busy slide, but this is one example of the clinical guidelines, the treatment-based classifications that we developed for each of those 7 categories. So it's just a reference or a resource to all of you that if you've got patients with HD, they probably do fit into one of these 7 categories, and we've suggested some signs and symptoms that might categorize them accordingly, what the aims of physical therapy might be, and importantly, what some of the treatments are. Now, we did this in 2009, 2010, and again, prior to really having any evidence to back this up, and now what we're trying to do is to test these interventions to see if in fact they are effective and if these categorizations are valid. But I think they still are, I think, helpful to provide a guide for therapists, and I think also importantly we have outcome measures listed there at different stages of the disease that might be helpful. So the therapy for people with HD are to maximize patients' physical functioning, their health and well-being, and their participation in home, work, and life skills. And the interventions in the early to mid stages really focus on mobility, so walking, sitting, and standing ability, general health and fitness, and trying to address specific impairments that we know are common in the disease. So balance training, strengthening, and exercises to improve range of motion and flexibility. And we know that from a general therapy perspective that those are reasonable approaches to working with patients with degenerative diseases. But can we also think about physical therapy in sort of a broader context, and that of promoting brain health? So not just improving patients' function, which, don't get me wrong, is extremely, extremely valuable in improving quality of life, but I think we also have a potentially interesting role in pre-manifest and very early stages of the disease, where we might actually be doing something to change the course of the disease. So this is a figure developed by Petzinger and Beth Fisher out at USC, mainly for Parkinson's patients, but I've stolen it and adapted it to Huntington's, where if we think about goal-based exercise or task-specific therapy or functional training in combination with, sort of intensive aerobic exercise, we know from research in Alzheimer's disease and in healthy individuals and now in Parkinson's disease that this can have a twofold approach. We can have improved brain health just simply from the increase in blood flow. It results in increased neurogenesis, we have increased metabolism, and increased trophic factors. But also on the other side, we have improved synaptic strength, so this idea of neuroplasticity. And aerobic exercise has been shown to be a very powerful neuroplastic agent. And might this be useful in very early stage HD to strengthen the circuitry within the basal ganglia and the cortex and the thalamus, which play such a critical role in motor function and motor output. And this results in the improved behavior that we might see in some of these outcomes of why people feel better when they exercise. They have improvements in motor function, both conscious and automatic motor function, but especially in other diseases, in Alzheimer's and in mild cognitive dementia, we've seen changes in cognition and executive functioning. And very importantly, in motivation. In patients with HD, there's lots of behavioral and cognitive and mood-related issues that I think aerobic exercise could really have a very powerful impact on. So this is kind of just the model that I like to think about when I'm trying to understand how exercise and physical therapy combined, because I know, exercise is a part of physical therapy, but aerobic exercise in particular, in combination with some of the traditional physical therapy balance, functional training that we do, could have this synergistic effect in HD. So the next part of the presentation, I'm going to be going through the different interventions, and I've classified them on 5 general topics. We have some evidence for exercise interventions and also for home and center-based, pretty much traditional physical therapy approaches that have been used. I'm going to go through some of that research. There's been quite a few papers in the past 3 to 4 years on multidisciplinary inpatient rehabilitation. So I will present the work from those studies. And then I'll just give an overview of some of the new approaches that have been put out, so BFIT and Engage HD, and a walking program that has been done over in the Netherlands. And then I'll highlight some of the key components of a falls management strategy. Okay, so we'll start off with exercise interventions. So the work in exercise interventions has been done with the group that I worked with at Cardiff University. There's two main studies that I'm going to present. The first is COMET HD, which was a 12-week gym-based exercise program. And the main question here was to see if it was safe and feasible to get patients with HD to be able to go to the gym and exercise in combination with a 2-time-a-week walking program at home. So giving them a progressive walking program where they're monitored their steps and their walking and their heart rate, and going to the gym once a week to do this combined aerobic and functional strength training. So the important thing about any of these studies is having blinded assessors so that you're not biased in terms of the outcomes. This is one of the difficult things in physical therapy. We really want our patients to do better, so we might sort of have this unconscious bias towards their improvement. So having blinded assessors who don't know which group the patient is in, and having randomized groups, right? And not just looking pre-post exercise, which is certainly important. And I encourage, anyone who's listening, if you do have patients with HD and you're interested in doing case studies, we desperately need them. But if you're doing a larger scale study, you definitely want to have this, a control group that you can compare the differences if either they were doing nothing or doing a different type of intervention, and you definitely want to have blinded assessors. So the results of this study were that there were no adverse events, so it was found to be safe and it was found to be feasible. There's very high adherence rates to the study. But there was relatively small effect sizes for what we would consider the functional measures, like the 6-minute walk and the UHDRS total motor score, which is a disease-specific motor function assessment in HD. What they did show improvements in was the mental component summary of the SF-36, which is essentially a quality of life measure. So they liked it, they felt better, but it didn't really result in any significant improvements in terms of their function. And so you might think, why might that be after a 12-week exercise? And our feeling really was that the exercise intensity was just not efficient to achieve the training effect. So you really need something more, I think, supervised and monitored, and making sure that people are getting within that aerobic zone and are being progressed appropriately. But they did like it and they did enjoy it. So we went on to do an extension study from this called Exert HD, which we've just finished up the results of. And this was a 50-minute structured exercise intervention 3 times a week for 12 weeks. So we kept the length, but we increased and the duration, because it was 3 times a week, but we made sure that it was a structured intervention and that they weren't just doing a walking program, but they were doing the aerobic and the resistance training at the appropriate level for 3 times a week for the full 12 weeks, so up to 36 sessions. So one component was the aerobic exercise, and this was 25 minutes of exercise on a stationary bike. And it was either an upright bike, as you can see there on the left, or a recumbent bike. And these are actual patients from the study who were on the bikes. And we had them working within their in an aerobic zone. So that was 65 to 85% of their age-predicted heart rate max. So they sort of had this this warm-up, they exercised for 25 minutes, and then they had a cool down. And then we did some what we called functional strength training. So it's really difficult to think about strength training in patients with Huntington's disease, mainly because of the choreic movements and then coordination. So we tried to find some exercises that we thought that everybody could do reasonably well, and with the proper technique. That was a really big sort of issue. So we did a sit to stand at the bottom there, and ways that we progressed all of the exercises were either by adding weights to them. So you can see the gentleman on the right there has a weighted medicine ball, or by increasing the repetitions. We had a plank, which is a general core strengthening, which could be measured in progression easily by increasing the number of seconds. And the plank actually started off against the wall, but most people pretty quickly went down to the floor. And then we had lunges in the top right corner there. Most people couldn't add a weight. They had a difficult enough time just doing the lunges without any weights. And then we had wood chops, which is a sort of general upper extremity trunk rotation exercise that we did. So it took about 10 to 15 minutes of that and progressed accordingly. And so the results, again, was a very high retention rate. 14 out of 17 participants completed the intervention, and there was very good adherence to the exercises. We had a very nice improvement in predicted VO2 max, which improved after the intervention. So you could see assessment 1 on the left and assessment 2 on the right there. You can see the increase in the intervention group of about 500 milliliter minutes, which was a nice change in fitness. And they also had about 3 points lower, so a 3-point improvement on the modified motor score, which is a subcomponent of the total motor score of the UHDRS, and it incorporates mainly voluntary movement abnormalities. It doesn't take into consideration chorea and some of the involuntary components or eye movements. So it really focuses on voluntary motor function, and they had a significant improvement in the modified motor score. But we didn't see changes in any other factors, such as cognition. We also measured dual tasking and walking ability, and none of those changed. And again, you might think, well, maybe it wasn't intense or long enough to show an effect on those aspects, which may certainly warrant a longer-term intervention, and it may be that it just takes a little bit longer to see those effects. But the effect on fitness, I think, is really encouraging to show that patients can improve their fitness, because that has been shown to be correlated with cognition and brain changes and brain function over time. So a longer scale study might show some nice improvements there. So now I'll go on to home and center-based intervention, and there's been a range of different studies that have been done. One of them has been what we call the Move to Exercise study. So this was done by Hanan Khalil, who is now at the Jordan University for Science and Technology. And she did, for her PhD work, a home-based DVD intervention. And there's quite a few home-based DVDs that are available. I know Deb and Ann at Ohio State have developed one, and we have one, and Ash Rao at Columbia with me, he's also developed one. So there's definitely DVDs available for patients and for therapists if you're interested. But this was a study that did a pre-post assessment with a control group of doing the exercise DVD at home with relatively minimal input by the physio. So the physio came in, she set up the program, she made sure that the patient could do it properly, she gave them the range of exercises to do, and then provided a lot of supportive phone calls. How's it going? Do you have any questions? And then would see the patient a couple of times through the intervention period, and then did the post-assessment. There were some really nice improvements, as you can see the difference in the green lines here between the exercise group before and afterwards. Again, there was this decrease in the motor score, pretty much about the same as what we've seen in the previous trial, the Exert. But one of the things that improved really nicely here was walking speed. It improved quite significantly in this group. But one thing that you can see here is that this group at baseline was much slower than the control group. So they became very similar to the control group after the exercise. So that's one of the limitations of this kind of a study, is by just per chance you might get groups that are different at baseline. This group also improved at their Berg balance scale and sit-to-stand test, the number of repetitions of going from sit to stand, as well as the PPT. But importantly in this study, and I think this illustrates it very nicely in many respects, is that this assessor was not blinded to the outcome, to the group. So the person doing the assessment was the person doing the intervention and knew what group both patients were at. And while these results are very, powerful, there might be some bias in here, and I think they certainly have to be interpreted with caution. I think also importantly was the patients, some of the patients stopped using the DVD once the support was withdrawn. So some patients absolutely still kept continuing with it, but those tended to be patients who had support at home and had caregiver support and encouragement to continue to do the DVD. So here's the overview of the DVD. I'm not actually going to click onto the YouTube channel, but this is a link to the YouTube channel, so I've provided it down here for you. And we've actually made the entire DVD freely available on this YouTube channel, so anybody can go on and use it. And it was specifically designed, we've tested it now in a couple of different studies, and it was specifically designed for people with HD and Parkinson's disease. And you've got, you can either be seated or standing to do the exercises. So there's models kind of showing you both. And there's a warm-up, a balance and coordination section, a resistance training, a strengthening, and floor exercises. And these are just kind of the figures that go along with it to show the kind of exercises that people do. So moving on, another home-based intervention that was done was by Klus et al. In 2003, and this was with a video game called Dance Dance Revolution, if anyone's familiar with that. And they looked at that compared to a handheld video game. So they did this for 45 minutes, twice a week for 6 weeks. And you could see the study plan here where they had a crossover design where patients first did the Dance Dance Revolution and then they did the handheld video game. And the other group started the other way, they did the handheld video game and then they switched. So this crossover design is one model for doing an intervention study versus having a control group. So everybody gets an intervention, you can test the differences. So they found it to be feasible and motivating and safe for patients to do, and they enjoyed it. And there were some significant improvements in double support percentage, so some gait parameters did change, but those did not carry over to functional improvements. So they improved kind of their balance components of walking, but not function per se. Another study that was done I think this might have been in Germany, no, it's Germany, yes. So this was done in Germany and in Sweden, actually. I think there might have been either 2 sites or it might have just been in Sweden, but with some German researchers. So they had 12 participants with HD, and they looked at what we would consider a really traditional physical therapy program. They didn't have a control group, but they were doing a pre-post assessment. But what they did do, it's really important if you do a study without a control group that you have multiple baselines. So you look at the changes potentially in the slope. So they had assessment 1 and assessment 2, and they had the intervention between assessment 2 and assessment 3 here. And this was just what happened on the Berg balance scale, but just to go through the intervention, they did transfer training, postural stability training, balance training, and there is some description of what the intervention was, but it's not, I think, as detailed as many of us might like, because these are relatively broad terms. But they did try to progress the patients, and they did work specifically on goals that the patients had. They did motor coordination and they did relaxation. So they kind of, followed a set structure. They did see some changes similarly in various gait parameters, an improvement in gait velocity, the tug, and the Berg. And you can see the Berg outcomes here. From assessment 1 into assessment 2, not much change. One thing you might note is a lot of variability between subjects. So these are medians and interquartile ranges, so you can just see how much the groups varied. And what happened over time between the first, the second, and the third assessment, and really from the fourth assessment, which was after the intervention, was those who seemed to be doing quite bad leveled out. They came to where the sort of mean of the rest of the group is. So that variability and that standard deviation actually shrunk, even though there was a significant improvement from this group to this group, but it's relatively small. That looks like it's just a couple of points, which we wouldn't say even meets minimal clinically important difference or minimal detectable change for the Berg, because the Berg is at least a 4, a 5, a change of that is what we consider sort of meaningful. But you can see this sort of change that happens over time with the groups becoming more similar to each other. Another study that was done similar to this was something called Train HD, where we did a home-based intervention, and I'll just play this video for you so you can kind of see what it was like. This was a study that was done in England, and the focus of this intervention was on what we call task-specific training. So we did sit-to-stand, standing balance, and walking training, all within the patient's home, focusing on, sorry about the wobbliness of the video, a goal setting. So what were the goals of the patient? What were they interested in achieving, whether it was, like for this gentleman, going for a walk around the block. So you can see the nice British landscaping there and the cars. And really trying to have it be, a functional task-specific program. And as I said, the focus was on, walking balance. Here's a patient doing some balance exercises outside. And we had a very standardized progression for this. So for this study, there was very high adherence. It's home-based physical therapy. The patients were really happy to have people come to their homes and really enjoyed it. I think they really enjoyed the interaction with the therapists. There was relatively small effect sizes for the standardized blinded outcome measures. So for things like the tug and the PPT and the 6-minute walk, they improved minimally, but not very much, if at all. But what they did do was exceed their goal expectations. So we used the goal attainment scaling to set goals for patients, and you can see here on the right the types of goals that patients set. So each patient set between 2 and 4 goals, so you're going to see more goals than there were a number of subjects. But most patients wanted to just improve their walking and improve their stair climbing ability or improve their balance. Sit-to-stand was also important, and some people couldn't come up with something quantifiable that they wanted to improve about their walking, but they just wanted to feel more confident. They were very nervous about falls and just their ability to go out and do certain things, and so confidence was a big issue, as well as general physical activity. Interestingly, hardly anybody cared about falls. Even though a lot of them had falls, they didn't think that that was a major issue for them. Now, certainly walking ability is very much related to falls, but falls in and of themselves weren't a big concern for patients. And what we saw at the end of the intervention was that a very large percentage of the participants met their goals, so well over 90%. So assessment 2 would be a much greater than expected outcome, and 0 is actually the expected outcome. So they actually exceeded their expectations in a majority of the cases. A few participants regressed, so we would set a certain goal, and then they would, if they didn't make it, they would get a -1, and if they got worse, it was a -2, and so a small percentage that occurred with. But for the large majority, they set goals and they met them. And that's very much what this intervention was about. So you might not expect that they would have improvements in standardized outcome measures that kind of cut across problems. And I think this really illustrates one of the difficulties in using standardized outcome measures in patients with degenerative conditions who have a lot of heterogeneity. When there's different problems for different patients, should we really be using one blanket outcome measure to look at changes? Or is something like a goal attainment scaling, where we're looking individually at patients' problems, a much more reasonable approach? I'm not saying for sure that we should do that, but I think it's something to consider. Okay, so I'm going to move on now to multidisciplinary rehabilitation. These are kind of the range of studies. There's been 4 main studies with a couple of publications for some of them that have been done that's looked at multidisciplinary inpatient rehabilitation and its effectiveness in people with HD. Now, this is something in the U.S. that is a slight bit foreign to us for people with degenerative diseases. We don't typically think of having patients with Parkinson's disease or Huntington's disease go in for an inpatient stay in a rehab hospital, but that's exactly what happened in these studies. So they took a model which we would think of using for stroke or maybe MS, or certainly spinal cord injury, and applying it to patients with HD who were in the kind of early middle stages of the disease. So I'm not going to go through all of the studies, but I'm going to give you an overview of what these studies show. So the interventions are generally on the average of 3 weeks. So they'll admit patients and they stay in the hospital for 3 weeks. They have a multidisciplinary intervention that focuses on OT, PT, speech, as well as social activities, recreational activities, and counseling is often a very important part of it. And they also have socialization activities. The intensity ranges a bit, but oftentimes they're getting, let's say, PT and several of these components 2 times a day. So traditional model in the U.S. is 2 times a day for OT, PT, speech, 6 days per week for a minimum of 2-hour sessions. So many patients, it was longer than that. And the outcomes, just to go through some of the outcome measures that have been shown in these various studies, it's been shown to result in improvements in the Tonetti gait and balance, the physical performance test, the Barthel, which I think it's interesting because it's not a terribly sensitive measure in this population, but Ciancarelli showed an improvement in that as well as the total functional capacity. The TUG, the 10-meter walks, the kind of walking abilities, the SF-36, as well as some of the UHDRS measures that have been shown by Thompson. And so here's just an example of one of the studies in the beautiful North Norway Rehabilitation Center there where this work was done. And you can see even in the top right there, the beautiful pool. It's a beautiful, sort of ideal settings for patients to stay in. And in this study by Pira, it was a 1-year program where they had 3 3-week stays. So they came in, they did an eval, they came in for 3 weeks, and then they left and had 3 months, and then they came back again and did another 3-week stint, and then left and another 3 months and came back again. And you can see the kind of range of activities there. This was highly intense, 8 hours of various activities, 5 days a week. They went on trips and did various aspects, and they had these various outcome measures before and afterwards. So it's a really, fantastic model and potentially can help to alter the progression of the disease. One of the issues sometimes is we don't always know exactly what the key ingredients of the intervention are. Ciancarelli was one of the few to actually list out what the activities were that the patients did. So you can just see here, they're kind of a wide range, but at least it provides some detail about what was done during the exercises. So they sort of have global or sort of gross motor, neuromotor exercises, as well as a range of fine motor exercises that the patients performed. I think one of the interesting things about multidisciplinary rehab is that it's been shown not just to have improvements in those functional measures that I showed earlier, but one recent study by Cruikshank, which this group is down in Australia, has shown that multidisciplinary rehab can actually improve brain structure. So this figure shows here improvements in the dorsolateral prefrontal cortex, which you can see here in the red in the top figure here. So there was an improvement actually in the volume, in the gray matter volume of this area of the brain before and after rehab. And this change in volume was correlated with a cognitive measure, the recognition discrimination index, which you can see here. This was a really nice, it was really the first study to show any significant changes in any sort of brain structure or function measures, specifically related to a very intensive intervention. So that has some nice potential, and I think provides some nice evidence for us to show that these interventions can be not just nice for patients, they enjoy them, but that it can improve function and that it might actually do something in terms of the biochemistry and the function of the brain. Okay. The limitations of this is that you don't have a control group. It's unclear with all of these. They just had patients who were receiving intervention and not any control group. So that limits the interpretive, the findings that you can interpret and what you can say about it. It's unclear, as I mentioned, what the active ingredient is, so I think we really need to be defining those. And I think really importantly for us in the U.S., it requires an inpatient stay. So all of these studies were done in Europe or Australia. And is this replicable in the U.S. healthcare environment? And I'd love to think that it would be. We have some great rehabilitation hospitals around the country, and it would be fantastic to be able to see this model replicated here in the U.S. So I realize I'm running a little tight on time, so I think I'll be able to finish in just the next few minutes. I want to just quickly go through some of the new approaches. These are not studies that have strong evidence. They're just, the BFIT is something that was presented at CSM, and actually a paper just came out on it that described the intervention. But there are some newer programs, and I just wanted to mention them. So the BFIT model, if anyone was at CSM, Ulansky and Danzel presented this model for Huntington's disease, and they just have a paper out, which I just got a copy of today, in Physiotherapy Theory and Practice, I believe, that describes this. And it's a community-based intervention for people with HD, and they've developed this model, sort of a four-tiered approach in working with patients where they're focusing on balance, which we know is a big issue, the functional task-specific training, the intensity piece, so the kind of the exercise bit that I talked about earlier, and trunk stability, which they felt was really quite important with patients in thinking about postural strengthening and core strengthening and awareness of body and space. And what I liked about this model is they really tried to take the research, all these pieces that I've just shown you, and pull it together in one piece and say, I think this would be a model intervention for patients with HD. So they're starting to do some research and testing this, but if anyone's interested, the paper has just come out, and I think it's worth a look at. Another important component is thinking about engagement of exercise and getting patients to do more in the realm of self-management and just increasing physical activity. So not going to physical therapy and doing exercises, but just how can in your day-to-day management could you increase your level of physical activity. So this was an Engage HD study that we have done that tried to improve patients' ability to be more, take more control about their physical activity. So we do this by looking at their autonomy and their competence and the relatedness, and it's what's called the behavioral change intervention. So trying to get people basically to be more active. And that's a quote down there at the bottom from one of our patients, which I thought was nice. When people talk about exercise, they think about gyms and things like that, whereas if you describe the type of exercise, explain that people can get benefit just from simple steps, I think that's quite important. And so we do try to emphasize that with patients. And in this study that we're just finishing up the analysis of, we looked at patients doing this Engage intervention where we did this kind of lifestyle approach compared to, we actually had a social contact control arm, and we saw some really nice improvements in the IPAC, which is a physical activity questionnaire. So patients who did this intervention improved their level of physical activity, and they also improved their self-efficacy for exercise, which meant they felt more confident in exercising, which was a nice outcome. This just really quickly is always a very motivating video for me to see. This is in Overdijn in the Netherlands, where there's a fabulous group of physical therapy researchers and clinicians doing some great work, and these are patients with Huntington's disease going for this walk in the dunes along the sea. And this was a poster that was presented a couple of years ago that showed with these patients who are involved in this walking group, and they do it 1 hour a week with a physiotherapist and a gym instructor. This was 1 year pre-baseline and baseline, and you could see the decline, and this is the total functional capacity score. But as they start to do the exercise program, it starts to level off their functional decline. And so their patients tend to do very well and remain very highly functioning for a long time. And I think in large part because they get a lot of activity, and one component is that. that walking program. Okay, so really quickly, falls risk assessment, we have some cutoff scores for various factors that might relate to a person being at fall risk, which I think Ann and Deb covered a bit, but it's important to think about who might be at falls risk. We don't have any interventions that have shown that any physiotherapy or any exercise can reduce falls or falls risk, so that's something that's very much needed. And I just want to emphasize here that it's really important to think about, just because someone is at risk for falls, it doesn't mean that they should, we should prevent them from ambulating or really limit their ambulation, and that we really want to try to balance out those risks and benefits with limiting ambulation. And loss of ambulation, importantly, is the #1 predictor of nursing homes, so we really try to keep people walking for as long as possible, but using things like environmental modification, footwear changes, and different interventions to promote safe performance of daily activities, as well as behavior management. And you could see here things like use of a four-wheeled walker. There's been some research on this. The group at Ohio State has looked at the differences between different kinds of walkers, and this four-wheeled rollator or U-step has shown to be the best, I think, for patients with HD. And also things like environmental modifications, helmets, which I know a lot of patients don't like, but as they get towards the middle stages of the disease, many patients will wear them or use hip protectors or elbow pads or knee pads, or importantly, making sure that the environment is safe. And the other thing is looking at footwear, and it's one of the first things I do with patients is making sure that they've got the right kind of footwear, because you can really get a lot of ankle instability that results from the foot and ankle dystonia. So in summary, aerobic and resistance training exercises have the potential to improve fitness and motor function in HD. Home-based interventions may help to improve functional goals, but may not result in any disease-modifying effects. And that's just from the research that we've looked at to date. These multidisciplinary inpatient rehabilitation, which incorporates physical and occupational therapy and speech, as well as social, may have the potential to moderate the disease progression and might be really important functionally and for patients' quality of life. But I think our real focus should also be on early stage intervention and in pre-manifest, where no work has been done, and trying to facilitate increased physical activity and engagement in exercise to minimize and potentially slow the effects of the primary and secondary impairments that we see. And just getting back to the slide from the beginning, we're now at a point where we're maintaining, hopefully, and maximizing functional abilities. We've shown some of the research for that, but can we think about ways that we might contribute to interventions that could delay or even prevent the onset of the disease? And some of the future directions, we still don't know a lot about late stage management and what some interventions are at that stage. We're looking a lot at using wearable activity monitors to track patients over time, as well as telemedicine for patients who are in rural. HD is a relatively rare disease, so trying to facilitate exercise adherence in that way, and more intensive aerobic and resistance training, and particularly in patients with pre-manifest. I've provided the link here for our website in the UK that has a lot of different resources pulled together, as well as our physiotherapy guidance document. And I would just like to acknowledge Monica Bussa, who is my colleague who I do all of this work with, as well as Ann Rosser, Katie Hamana from Cardiff University, Karen Martyr, where I am now at Columbia, as well as the HDN Physiotherapy Working Group and all of the patients and families from our clinics and our research studies. So, and I have a bunch of references which should be on your handouts, and I think that's it. I'm sorry I went a little over what I thought I was going to, but I'm happy to answer any questions at this point.
Thank you, Lori. That was really fantastic. As we're waiting for folks to type in their questions, I did have one for you. Since falls are the main contributor to nursing home placement, you referenced the EHDN guidelines for falls. Could you take a moment to talk with us a little bit about what the 3 or 4 main points are in reducing fall risk that a community-based physical therapist could use in advising their family members?
Sure. Okay, absolutely. We do have this, and actually on that website that I showed at the end is the full HDN guidelines for falls risk management in HD. We don't, so I think one of I think the major issue is the environment. I think it's often a major contributing factor to falls risk in patients, and so doing things, you know, that you might do in any clinical setting or in any home care environment to make sure that the environment minimizes the risk for falls, from things like, you know, throw rugs and positioning of the furniture and decreasing clutter, but also importantly to keeping a consistency of the environment. We often find that when things change for patients is when they're most at risk for falls. Another big risk for falls in patients is distractibility, and we hear this over and over and over again. It's when they were doing two things at once or somebody distracted them and they were walking and somebody said something and then they turned and then they fell. So to the degree that we can, training for dual task and minimizing distractions and having patients try to minimize doing two things at once and focusing in a way that they might not have been used to. You know, patients will say as we see them going through the progression, oh, but I used to just be able to run up the stairs, you know, with the wash in my hand, and now I can't do that. And it's helping them to manage those changes as they happen. You know, seeing them, you know, we like to recommend having patients be seen by a physical therapist every 6 months so that we can start to catch some of these problems and head them off beforehand. Again, I think a major issue is footwear, and in terms of even causing, you know, falls and being a contributor to them, because you'll see patients who have difficulty tying their shoes, so their shoelaces either come undone or they're on very loose and they don't provide enough stability for them. And then, you know, the balance aspect is a major one. So turning and, again, dual tasking, and they tend to, you know, stairs is also a major aspect. So functional training related to dual tasking, walking, and stair climbing, I think are also, that would probably be my fourth aspect of something that's really important to pay attention to.
But a lot of what you just said would be in the EHDN guidelines that you have as a reference in your package, correct?
Yes, exactly.
Okay, that's great. Any questions? Okay, we don't have any questions, but I do just want to show one more slide for folks who are with us on how they can obtain a certificate of completion for the module. Please go to the link that's shown here, surveymonkey.com, with the PT Mod 3 to access the post-assessment test and registration for your certificate. You must score 75% on the post-assessment test to be eligible for the CEU, and you must complete the certificate information so we can send you the certificate. If you have any questions, please contact me. My email address is there. Our next session is going to be on June 14th, Physical Therapy Management of Individuals in Late-Stage HD. And to register for Module 4, you can go to the web address shown below and click on the link for Module 4. If you missed Module 1 and Module 2, the links are shown there for those as well. If you have any questions or you can't write these all down quickly enough, just contact me and I'll be happy to send you the links. We do thank you for your time. We thank our presenter, Lori Quinn, for this really excellent webinar today, and we look forward to seeing you on June 14th. Thank you very much.